presentation whenever you're ready.
Great, thank you. Okay. Sorry about that. I don't know if I had the wrong link. So today I'm going to discuss a burns case, a couple of burns cases that I managed while working with some of my colleagues in Uganda. Some of them it looks like are on this call. So I'll just get started. So I was assigned to work at a hospital, public hospital in Uganda. It's a regional referral hospital in the eastern part of the country. It serves quite a few districts, and so it has more resources than a lot of hospitals within Uganda, but still relatively low resourced. We have a high dependency unit, but no ICU. There's only one ventilator. There's no arterial or central line catheters easily available. There's only 3 operating rooms with 4 surgeons, 1 medical officer, about 10 surgery residents, and 10 interns and medical students who provide surgical care. It's very limited nursing care. Generally, there's about 1 nurse to provide care for an entire ward of about 20 to 40 patients. And then resources are very scarce within the hospital. Patients are generally expected to buy all medications and supplies, and then running water and electricity are often not guaranteed. This is just a picture of what like the open air ward looks like. This is another ward. Okay, so first case I'm going to start with is patient JC. This was an 8-year-old girl who presented to us around March 2024, so this was over a year ago, after hot water and oil was poured on her by her grandmother after attempting to steal some fish. Unfortunately, I don't have the initial pictures of what the burns look like. This was pretty soon after her presentation, but obviously some debridement and eschorotomies have already been done. But you can still see how severe the burns are. She's already starting to have necrosis of her fingers and still needed a bit of debridement of her deep burns that were evolving. This was about a month later into her injury. Some more debridement happened, and still was doing routine wound care. Still hadn't had great granulation tissue yet, but had started to develop some granulation, pink granulation tissue. And basically we were limited in our ability, we'll get to this, to do things like grafting because we didn't have a dermatome, we didn't have a mesher. I had to buy my own Humvee knife, and there was limited OR space. So largely these burns were being managed with wound care, unfortunately. And the wound care we were doing was not super consistent, again, because limited nursing care and wound care supplies, but generally there was a mix of like honey being done as well as like iodine gauzes that were being changed every couple of days. This is in May, which was about a couple of months from her injury. You can see the tissues, she's developing more granulation tissue, but unfortunately definitely developing contractures, and also her digits were kind of fusing. It was difficult to get really good wound care in between all her different fingers, and there wasn't really physical rehabilitation or splinting services that were available for her. So yeah, so
Dr. Broecker, if there's any pause stops along the way that you want to ask the group questions or get feedback from, Dr. Untracked is here to help with that. I'm not clinical. I'm just here to help manage the meeting. So if there's anything that you want to ask the group, if there's any break points along the way, it's kind of like an open discussion format.
Great.
Yes, could I, well, let's
yes,
go ahead.
Go ahead.
Well, no, go ahead if you have any questions to ask the group.
Yeah, I had some questions at the end, but we can talk about this case once it's done.
Yes.
I mean,
Yeah,
basically,
I just, if I can maybe stop there and
yeah.
fascinating case. And how long had you been in Uganda when you saw this case?
So when I had only been there about a month when she first presented. So yeah, I was still adapting to the environment
Yes.
and
So
about
she
resources
came
there
as an
that are local.
outpatient. Is that right? To the outpatient clinic?
No, she came, I think, to triage. She came to casualty, and was
Or in other
admitted
words,
to the
she
ward.
had not been seen at the hospital and just came the first time to the emergency room. Is that, do I understand
Yeah,
correctly? Yes. Okay.
yeah, and
And
I mean,
so,
I think.
yes.
Oh, go ahead.
And had she been seen before there?
Not that we know of. And the
Okay. So who do you
documentation is
think did
not
those
very great.
treatments with the escharotomies and
Oh,
the
we did this. We did this.
oh,
Yeah, this was
you
after
did
she
it there
presented.
on
Yeah.
the first
I'm sorry, I
trip.
didn't have.
Yes.
Yeah, I didn't have pictures of her initial burn. I'm sorry. I didn't
Okay, and
personally see her
right. So the
casualty,
burns
but
occurred before you arrived, and then after you arrived, she returned. It basically is an outpatient. She had not been kept in the ward. So, but
no,
if
she was
that's it,
kept on the ward.
she was okay. And so when you got there, she was already on the ward, and then she came to your attention.
Hmm.
Yes,
Yeah.
and so and then how long is this the first time you'd worked in a remote hospital in a developing country with limited resources?
No, I had worked on mission trips to Haiti before, but I had not provided emergency burn care in a low resource
Yes.
setting. And then also usually when I did these medical mission trips, I brought a lot of my own supplies, which I tried to bring some supplies, but for the most part, I was integrated within the
Yeah.
health
So
system.
fascinating case, and I see that you also you work at Gallup Indian Medical Center. I had a colleague from residency who worked there for many years, and I visited that facility. I don't know how the incidence of burns that you see there, but I think just to comment, in developing countries, burns are very, very common because often cooking is done on open flames outside the
Mhm.
house. Just depending on the region, but usually outside the house. And many children come with burns like this. Although this is unusual, it's basically a case of child abuse. If that happened in the States and a 4-year or 8-year old, however old this girl is, I think she's even 8 is still young to have and a grandparent. That's very unusual. Developing countries, that's not something that you see, that kind of child abuse, especially by a grandmother. So it's unusual, and these problems occur very often in those locations, although not the reason, but burns like this. And the local people get very good at dealing with it. But this is a typical example of what you do in regions with limited resources. I actually worked in Lachor in Uganda, in the Acholi region in the northwest, and also in Sri Lanka and Haiti and many places where, especially Sri Lanka, teenage girls tend to light themselves on fire as a form of self-abuse and part of the suicide problem that they have there. And the wards are filled with these extensive burns. This is a case involving the child's left hand and the arm, so it's just maybe 5% at most. But even in
I think it's both
America,
hands.
oh,
It's
both
both
hands.
hands.
Okay, both hands. Yes. Okay, so that even involving the hands would be a case that would normally be admitted to a burn unit. So if you got this at Gallup, you would, if you had access, you would transfer a patient like this to the after the initial care to the regional burn unit. But let me just ask you if there's anyone else at the meeting who can comment. There, it looks like there are some people. Dr. Gambu Gamubaka, are you there? Would you where are you practicing? Dr. Richard? No, no one's responding. There, where are you?
I'm
There you
practicing in Bali.
in Bale. Oh, you know this case, right? Is this your case?
Yes, we know the case.
Okay, okay, very good. Yeah, but I think you'll be commenting later, I assume. But anyone else here who would like to, Dr. Palacios? No? Okay. But anyway, so this is, Dr. Richard.
Looks like
Uh,
Dr. Tavares has a comment.
Dr. Yes. Anyway, Dr. Richard Gamubaka, I'm sure they know what to do, even without a dermatome, how you would manage this case. And I think from the pictures you showed, the wounds seem to have been actually well taken care of, and they're clean, they're granulating. And even what you do in places with low resources is a very good experience for any surgeon who works in developed countries. I think it's an excellent experience for an American surgeon to go to places with limited resources and realize you can do 98% of what you do at your local hospitals with just a few supplies. But I think if no one else would comment.
Dr.
Looks like there's
Tavares
a
had something to say.
question. Yeah, Dr. Tavares, do you have a
Yeah.
question
Yeah,
or
hi, can you
comment?
hear me?
Yeah, we can hear you.
Yes.
Yeah, hi. I think this is a great case, and thank you, Dr. Broecker, for bringing it up, especially for I'm originally from the Dominican Republic, so I've seen some of this in the past, not so recent, but trained in the States. So most of our patients in burn centers get get treatment for the burns within 48 to 72 hours, and again early grafting. And this kind of highlights the reasons why we do this, right? Um, this is what long-term burn care without surgical management looks like. And often these patients succumb to infection. So it's actually, I think it's really surprising that this child had this, like, was able to heal without necessarily having a major complication, and probably suggests that she had really good wound care. So I was wondering, Dr. Broecker,
Mhm.
what kind of wound care regimen did we have for her? How often was she coming to the hospital for wound care? My experience in the Dominican Republic is that often we'll have patients come to the hospital just for the wound care because it's really tough for the patients and the patient's family to do it at home. They might not have access to water, might not have access to surgical supplies, and might not have the expertise. So they might need to come to the hospital several times per week just to get wound care.
Mhm. Yeah, well, I'm glad you brought that up because actually that was going to be, oh, this was just a picture of her follow-up a few months later. Um, so yeah, typically what we would do, I wouldn't say we had a clear regimen, and my colleagues like who are here from Uganda can maybe elaborate, but I wouldn't say there was a standard regimen. A lot of it depended on the patient's resources. Ugandans were very creative and would use things like papaya, pineapple, and honey because these are, more easily accessible and have antimicrobial properties. And so we would use honey pretty early on in a burn injury. Sometimes we would do iodine soaked gauzes and change those like every other day. But patients had to have be able to buy the iodine and the gauze, and that wasn't always so easy. And then on top of that, we needed staff to change the dressings, which wasn't always so easy. And then sometimes the wound care was really painful, and there wasn't really space or anesthesia support to provide good anesthesia. So it was quite traumatic sometimes to perform the wound care. Generally, patients like this just stayed in the hospital for months. This patient was in the hospital pretty much March to June. And until, she kind of had healed enough of her wounds that it was safe to leave. And so she would, just be in the hospital getting wound care every couple of days.
Yes, and she 8 months old. It looks like in those pictures much older than 8 months.
Oh, I had another case that was an 8-month-old. This patient's like
Oh,
eight.
oh,
Yeah, it
eight
was like
years
a
old, right?
young
Okay, so
child. Yeah.
yeah, right, and yeah, and it shows the difference. Modern burn care in the States and Europe and South America in the big cities is early. Is focused on early excision and grafting. That you do that early,
Mhm.
and the results are much better. And in developing countries, they're often treated like this, especially the more extensive ones where they just rip the dressings off and the patients are screaming and they scrub them and often for these patients if you have ketamine they take them to a clinic or a little operating room or procedure room, give them a little ketamine and get the dressing done that way. But anyway, any other comments on a case like this? But I think
So I guess I had a few questions that
Yeah,
maybe I'll just jump
go
to
ahead.
my questions at the end. I mean, I have one other case to discuss. Oops. But the questions in particular I had for the group, because, there doesn't necessarily seem to be a great consensus in lower resource settings. I've done a lot of reading. I tried to find as many resources as I could, but, recently the Lancet just published a paper actually in June talking about how there still is a lot of research that's needed to look at the optimal way to treat burns in a lower resource setting. So yeah, I think questions in particular I wanted to ask, well, like we talked about wound care, whether people have protocols that they use, especially with limited resources. If patients aren't able to buy things like gauze or iodine, do they use other things like honey or papaya? And if so, what is their regimen? How early do they start something like honey on a deep wound? Because you also want to, be able to change dressing more frequently early on to see how it's evolving. And then how do you surgically manage burns? Like I said, we didn't have a dermatome or a mesher, so we had to use a Humvee knife, which is not ideal for excising or grafting because it's compared to a WEC, it's much wider and not as precise. And so, and then how do you decide when to excise and when to graft? I think even grafting was really challenging for us, even if we could excise the burn, because a lot of the grafts failed because of lots of different reasons: delayed presentation, high risk of infection, poor nutrition, anemia. And so the decision to graft, was challenging to decide. And then like also how to manage. I have another case of a more critically ill patient, but that's a whole nother, maybe we can talk about that after that case, but how to manage like and triage more bigger burns, because it's more difficult to manage those, obviously. So,
Okay, anyone like to comment on these questions? I think they're very excellent questions. How you manage in a place where you don't have all of the resources that you have in a modern burn center, or that even in a non-burn center you would still be able to. You have all the resources needed to do the initial treatment. So anyone like to comment?
looks like Dr. Tavares.
Dr. Vega, was Dr. Vega the one from Dominican Republic?
It's like Dr. Tavares has his hand up again.
Dr. Tavares, there you
Yeah.
go. Go ahead.
Well, more than a comment, I have more questions, and that way we just can lump them all together. Split thickness skin grafts is very tough without the dermatome and almost impossible. But you could do some full thickness skin graft. So, um, did did you guys have access to do some of that? And for this specific case, was there any consideration doing that to prevent some other contractures close to the joints?
Yeah, so like I said, we even like a Humvee knife is not that easy to get. Like generally surgeons have to buy it themselves. And so by the time I bought a Humvee knife and got it, she was already like a month or so into her wound. And then at that point, she was malnourished, she was anemic, her hemoglobin was often 6. It was difficult to get access. I had to like order a central line from Kampala to be able to have routine access for her to prep her for the OR. And so, yeah, I would say we usually a Humvee knife is what's used, like you said, a 1-to-1 because there's no mesher. But even that often that was my experience, is generally grafts often failed unless they were like a very optimized patient, which this patient, you know, after having been fighting a burn for over a month, was not in optimal condition. She was very malnourished. So yeah, I think I tried to excise and graft her as quickly as I could, but yeah, the reality was we were worried the graft was going to fail. But yeah, it definitely, I agree, early grafting would have been ideal for her, especially dealing with the contractures. Yeah, I don't know. I really struggled. I don't know if other people from Uganda maybe have insight on how they've managed similar cases, or from other places, but yeah, I found it difficult to get a patient to the OR to graft and optimize them.
Dr. Tavares, you have other comments?
It looks like Dr. Kobe has a question in the chat.
What's the question?
How much water have you used for wound cleaning and how often? Oh, she just responded to that.
Yeah, I mean, again, patients would have to buy all the supplies. So they would have to buy the sterile water or saline and the dressings. So we tried to do that, you know, every day or every other day, but it just depended on if they hadn't bought the supplies, the wound dressing wouldn't be changed.
Yeah, and how about like normal saline for infusion? You know, for do you have they
Yeah,
have to buy
I
also?
mean, yeah, they'd have to buy that.
They
And
buy it at the hospital, or they have to go out into the town?
yeah, there's a pharmacy right outside the hospital gate. So generally, that's
Yes,
where
and
patients
they have
can
to
buy it.
provide that, and this is a government hospital that doesn't really doesn't offer free health care. Is that right?
I mean, in theory, help.
Yes. Okay.
Um,
Any other comments? Somebody's got their hand up.
Dr. Dennis?
Oh, Dr. Palacios has a question. No. Good.
Okay. Yeah, this is Dr. Dennis Kayumba. Can I be heard?
yes.
Okay. Thank you so much for this presentation. So wonderful and really so attractive because of the nature of the condition we are discussing. Yeah, I'm Dr. Dennis Kayumba. I'm also from Uganda, but I am a surgical resident from Makerere University. So currently I'm in Mulago National Referral Hospital, which is the national referral for Uganda. I have personally not practiced in Mbari regional referral before, but Mulago National Referral Hospital, being also in a similar setting, resource limited setting, but at least we have a Burns Center. Actually, it's another hospital which is also a national referral called the Kirudu. So it's a Burns Center, and I'm not sure about Mbare, whether it's a Burns Center, it has a Burns Center. But according to my experience in Uganda, really we face a number of challenges. We have a number of challenges, but at least where I am in the national referral, we have some of the few necessary equipment, like a dermatome, but of course, because of the overwhelming numbers, sometimes we find that actually we have limited capacity, limited dermatome to use. So we end up still using ambi knives, and quite a number of challenges definitely associated with that. Wound care generally in Uganda, like what is happening in Mbale, is quite similar in all other areas, similar challenges, and we really have a number of quite an overwhelming number of children who come in with burns, and quite a number of them are affected with the abuse, surprisingly. Yes, and many of them, especially now like this one who had the burn involving the hands and quite a number of joints here and there. Standard-wise, we would do like to manage such patients in the hospital initially because of the risks of contractures and so on, with the help of physical therapy. We usually have physiotherapists attached to those units, but still they are also very few. So you end up actually having very few sessions for such children. Very few to actually sometimes nothing, and they end up with contractures and so on, which is really not called for. Yeah, so we really face a number of challenges managing these patients. And what the presenters mentioned, the wound care, actually, that's also what we do. This side, we always wish that we do early tangential excision, but because of the overwhelming numbers, we find ourselves going for enzymatic debridements. We use a lot of papaya in Kirudu National Referral Hospital, but majorly it's because of the overwhelming numbers that we have. Otherwise, if challenges were not so much, we would really love to do early tangential excision, usually for full thickness burns, and then maybe those which are deep partial thickness, and then those would take more than 3 weeks if we have been managing, if we haven't been doing the excisions, and maybe I've been just doing the dressings, so wound care. So those who take 3 weeks and they have not healed, they are the ones that we usually consider for skin grafting. And also depending on the total surface area which has been burned. Usually above 20%, usually consider severe burns. Children, we tend to go to around 15%. And I think I've personally encountered patients who have total body surface area of 60, 70, 80, usually associated with a very high mortality rate. We in Mulago still, Kirudu, we don't have actual ICU for some of these patients who do benefit from that, which is also a limitation. So we end up managing those patients from an isolated room, which is not really well equipped to manage such who need the ICU. Airway, I think there was an issue concerning airway management. Those who have risks, for instance, inhalation burns, those who have edema, and we are seeing high risks of airway compromise. We tend to go for early intubation. In such patients. Yeah, that is in Lago, but I don't know in peripheral facilities like in Mali. I don't know how they usually go about to such, because even anesthesia, as the president already mentioned, there are also challenges to do with anesthesia. So early intubation may be also quite challenging in other peripheral facilities like Problem Valley. Maybe shall hear from a team which has experienced that side. But maybe that's the bit I can say about my experience in Uganda. Thank you.
Yes, and doctor, so you're in Mulago Hospital is the main hospital at in Kampala, right, the main government facility where they have all the best resources in all of Uganda. So there you would manage the case as closely as possible to the Western standard of early excision, fluid resuscitation and topical wound care to limit infection for the first few days, and then early excision and grafting. So, and I'm not sure in Malago Hospital if the patients have to run and buy every piece of gauze and every all the infusions and antibiotics and or the endotracheal tube if they need that, but still, fascinating. Fascinating situation, and something that is a very good way to for training in management of difficult cases with limited resources. Any other comments? No one else comments. Well, let me just say, in a case like the access to rehabilitation, Dr. Tavares was asking, what's the access to rehabilitation services? I think Dr. Broecker would say rehabilitation is done by instructing the family what to do at home, right?
Yeah, I mean, unfortunately, I never saw PT come on the ward. We did have PT that we could refer to patients to afterwards, but yeah, I mean, splinting was unfortunately not available
right. So,
for this patient.
Yes. From what Dr. Broecker was saying, the resources are so limited, patients really can't afford them. So the challenge here is, what do you do? How do you manage a case like this without impoverishing the family, and limiting the strain on the family and taking care of the child? And with a case like this, if it was extensive burns, that's about maybe 15 or 20% at most, but if it was the whole torso, we have to give fluid resuscitation. The initial priorities are fluid resuscitation and prevention of infection of the burns and early excision and grafting. In this case, that would be modified a bit, because here what they do in developing countries, they still do this as just put dressings on, let the wounds slowly heal, the same way the burns used to be treated in the 1960s and 70s in the States. You let whatever's going to necrose, and then you put them in whirlpool baths and you pick off the dead tissue as it forms, and eventually you get a granulating wound, as you got with this child. And once you see the wound granulating, then the child is ready for grafting, because the bacterial load is low enough. A graft will take on granulation tissue that covers any tendons. So to compromise for the low resource location, it's reasonable to, if you don't have Silvadene or silver nitrate, it's okay just to put plain gauze, wet it, and then pull it off dry. And the children cry, and it's very uncomfortable, but you get it done. And you can use plain tap water, is what they would use in Sri Lanka, and just scrub off any dead tissue until it becomes granulating. In the meantime, you need to prevent not only infection, but prevent the child from getting malnourished. And in this case, all she needs to do is eat. So they need to bring her milk. They can put oil and sugar in the milk. If they have meat or rice, then they need that. And she needs to be hand fed, because she can't use her own hands. That's the issue here. So, and those are all things that the family can do. Although in this case, I'm not sure why the grandmother, what the family situation is. Was this just sort of a mistake that the grandmother did, or is this child not taken care of, or don't you know, Dr. Broecker? Do you have information?
I mean, it definitely, I don't know the details that well. My understanding is it did sound like child abuse, and the grandmother basically disappeared after that. Yeah.
Yeah, so the child needs either good parents or good guardians, either relatives from the community or other people in the community that know her and can take care of her. So those are all things that you can do without having all the fancy equipment and the shiny, resources and the air-driven derma. You don't need any of that. And then the pictures that you showed, looks like this girl was ready for grafting at this point. So, you can still continue the dressings because they were working. And in the meantime, you can, if you have plaster, you can prepare some splints to keep the contractures minimal. So, for example, that one hand, it looks like the right hand is developing a flexion contracture at the wrist. If you do some splinting in between, that would minimize there. And then for grafting, what's often done in these locations where they don't have even a hand dermatome is to use a number 10 scalpel blade and do a bunch of small pinch grafts, each the size of a postage stamp, and then pie crust the graft, basically mesh it with the tip of the scalpel. Very time consuming. It takes a long time, but that's the best you have. And the people in these locations where they deal a lot with these burns, they get fairly good at doing that. So, you can take a split thickness skin graft just based on the skill that you can develop with a scalpel blade, and first graft the flexion areas, wrap them up, keep them wrapped, get them to heal. And those nicely granulated areas, the rate of rejection should be rather small, and just little by little you can get those areas covered. And the more grafts you put down, you can spread them out, and each one will send out epithelium over a wide area. So you can put them densely over the flexor areas and the antecubital fossa and the wrist, and then spread them out widely over the forearm, and eventually the wound will get fully epithelialized and you're done. So there are ways to do that, and it's just a matter of being creative, thinking outside the box, trying to, in your mind, knowing what's essential, and doing those things with the resources you have. And then also learning from the local people. If you see the way they manage these, it seems rather harsh and rather cruel, very painful, a lot of screams from the burn unit, but it works for them. So you can manage, and it looks like you were managing in this case.
Yeah, I think, oh, did someone have a comment?
Do you have the outcome, the final result? Or this is the final
Yeah,
result?
so,
Oh, that's a year ago.
Yeah, yeah, unfortunately I don't have a more updated picture. This was the most recent photo I had, which was, a year ago. Kind of asked her to follow up, but she had, started to heal her wounds, clearly had devastating contractures and deformity of her hands. I mean, I would say her hands are non-functional. So yeah, not a good outcome by any means. And we really struggled with this case because, in particular, she was so malnourished and anemic, and it was difficult to get access that even once her wounds finally, looked ready for grafting, we just couldn't optimize her for the OR. Her hemoglobin was consistently 6. It was difficult to get access to give her blood. She wasn't really getting good nutrition. I think I didn't quite understand the social dynamics. But yeah, it didn't seem like she was well enough cared for. So I think we might have attempted a small graft, but largely, the fear was that, I mean, anesthesia wouldn't operate on someone with a hemoglobin of 6. So yeah, we really struggled to optimize her for theater and grafting.
Yeah. Do you have plaster slabs there to make casting for fractures and all of that?
We do. Yeah, we could have plastered.
Yeah, because in this case, you can make splints and reuse them just one time. Make volar splints and then wrap the extremities. And she needs somebody to help her with her activity of daily living because of lack of the use of the hands. But even in this case, I think it's still salvageable that she can. If she can have the wounds prepared and then maybe some splints on and dressings. I don't know what where's your colleague, doctor, your colleague from Bali, the option to have patients go to Malago Hospital. If they go there, if it's the same issue that they don't have access because of lack of money, or what is that an option to refer for the final grafting? maybe somebody can comment on that. And then the last thing is when contractures develop, there's the rehabilitation surgery in late cases. Those are easy to treat just by contracture release, just cutting the tracture transversely 90 degrees to its direction. You get a big open wound and you can immediately put a graft on it, and then that'll heal. So those are things you can do after the wound is otherwise healed. There are ways to manage, and you can get good results even in developing countries. But it is a challenge, and it's very, very good experience, especially for young surgeons. Learn from the people there, and then bring your own knowledge and see how you can adapt to a difficult situation. Any other comments?
Oh, he has a comment. Go ahead, Dr. Gamble.
Dr. Richard.
Yeah, thank you so much. This case, the child, like she has said in the pictures, you see that most of our patients, the biggest challenge we have in Mbale, and I think it's everywhere in Uganda, most of our patients come to us late, very late. And this was like a homicide or something like a criminal. The grandmother, first of all, hid the child for some time until the situation was overboard. That's when the LCs, and actually we tried to follow up on the case, the LCs and then the people around, the neighbors, insisted that the child should be brought to the hospital. And that's when the child was brought to the hospital. But ideally, they come to the hospital when they are having a lot of things that they have applied on their burnt wounds. So most of the time, by the time they come to the hospital, the wounds are infected. So grafting would not be the best. We first manage the wounds first before we can think of grafting. But yes, we do grafting, but still we have a lot of challenges in grafting. Like she said, we don't have dermatome, but we have the ambe knife, where a patient has to buy their own blades. So we also have that one. We don't have blades which are supplied by the government of Uganda, but if a patient is able to buy a blade, we graft. If not able to buy a blade, still we can use the surgical blades to try to harvest. Of course, the skin is not in the correct dimension for grafting. But we still have a lot of challenges in that. But however, the child came back for review and still is having the contractures. So even if we initiated the physiotherapy department, the physiotherapy department started doing exercises for the child and told the grandmother. But the challenge is, since the grandmother is the one that committed atrocity to the child, now the grandmother now fears. So in most of the cases, the instruction is given to her by the physiotherapist. She was fearing. So we were left in a dilemma. But ever since, I think she came about 5 times for review, but now she has disappeared. I remember one of the heads of department wanted to institute the social workers of the hospital to try to look for the child, but we shall just try to follow it up. But that is how the case went. Thank you.
Yes, and I'd say, Dr. Richard, so obviously, you have experience dealing with these difficult cases, and you dealt with it beautifully. Just looking at those photos, how there's no infection, the wounds are granulating. So, and all the things about using pinch grafts with a surgical blade, all of that. And really, the biggest problem here is the social situation. So I don't know what protections the police can provide. In the States, the child would be taken away from the grandmother and put in a protective situation. And in this case, I think the child just needs to be adopted away from the grandmother, who may have mental illness. I don't know why a grandmother would do something like this, but there you go. So difficult case, and I think that the biggest problem is the lack of follow-up because of the social situation, but otherwise handled beautifully from a medical.
Yeah, that is very true. But sometimes, sometimes we employ the social workers. We have the hospital social work who tries to trace out together with the police, the relatives of these people, so that the child is handed over in another custody, not back to the grandmother. But sometimes you find out that the only relative the child is having is the grandmother, and you can't trace even the other members of the family. So we end up, and even the police and Uganda, we don't have a place where we can withdraw the child, and then the child is under state's protection. That is not, it's not there.
Yeah, let me, also there are other options, a few, since we have a couple of minutes, how to help this girl. Do you have access to the child? Does she, say, lost a follow-up, but does she ever come back to clinic or any way you can find her?
Yeah, she came back for review for about 5 times, but from that time we lost contact with her.
No,
but of recent,
yes,
of recent, the head of department instituted the social worker to try to trace her up and see if we can identify her, because there was some organization which was looking for some patients to help. So we thought of her. We usually put them in our book. We have a book where we can contact and see if we can help them.
Yes. So let me tell you, from my experience in that area dealing with colleagues, there are several options in this case. First of all, in the closest one is in Kenya, in Nairobi. There are some charitable organizations that and the hospital is run by the church or other charitable organizations that deal with cases like this. You just have to get there, and then they can help. The other thing is in the States, there's the Shriners Hospital for Children. My first rotation as a young doctor, 1981, was at the Shriners Hospital for Children in Boston, and they take children like this from all over the world, mostly South America and elsewhere in the States. But this would be a case where they would, if you can find the child and have information, and in fact, Dr. Broecker, if you can assemble with Dr. Richard the information about the child with the pictures and what she looked like, I can try and send them to my contact, and they get donors. They can, someone like this, if you can get to Entebbe, they can fly her out, and then they would arrange, the local family that can sort of be her guardian while she's here, and they can do the grafting, and then the rehabilitation of the hand. Looks like she has some syndactyly, developed some traumatic syndactyly. They could fix that. I don't know if she lost one or both thumbs. Did she have both thumbs still? She may have lost those. They would fix
her thumbs. Yeah.
Both of them. Both of them. Yeah, and they can do superb rehabilitation, either transferring from a toe to a thumb or policize. But since now this is just one case, and there are many where there's this one, there are others that fall through the cracks. But if you have the information, if you can get the information, and Dr. Broecker and Dr. Richard put together some pictures, with a summary, and then through Kevin, Mr. Miller, get them to me, and I can send them to my contacts. I can go back. The one hospital in Nairobi might be, but then again, it's getting there. So she needs, she has no family, no one to take care of her. That would be difficult. But the other option is the Shriners Hospital, and for them it'd be easy to raise the money for a flight from Entebbe back to the States, and then that she would live there for a year. Might actually wind up being adopted by somebody in the States, which given her history, I think whatever, at the minimum she should have access to optimum treatment for this horrendous injury that's very regrettable. Hard to imagine.
Thank you. Yes. Thank you, Stephen. I think I need to speed up the finding of this child.
Yes. Yeah. If get the social workers to do that, put together. You first put together a summary. I can contact the people in I forget the hospitals. There are a couple of hospitals in Nairobi that are excellent. I sent somebody from Uganda there who had it turns out a genetic defect. It didn't succumb to it, an infant, but they can either treat this one, they might be able to treat this, or the Shrine might be the easiest. Shriners Hospital for Children might be the easiest way. A case like this, they would look at this and say, yes, this is right up there. This is what they do, especially the one in Boston. They treat burns there, the acute and the chronic sequelae of burns. And I think they would be glad to handle a case like this. So
Yeah,
if you would,
I'll be happy to play middleman. If anyone wants to send something to me, I can forward it to Dr. Untracked. Absolutely.
Yeah, if you can send a group email to Dr. Richard, Dr. Broecker, and me, and so
Okay.
Do that, and then but I need this, this presentation. If you prepare something with photos, I'll send it on first to the Boston, and then I'll also contact the people in Nairobi to see what they can do for her. But yeah, the best thing you can do is the social workers, I think, would be the heroes here to get her away from a bad situation, and keep her there in Bale, and keep her fed, whatever, and then see what they can do for her. So. And I think there's no time for the next case, but maybe that could be added on to, is it another burn case?
Yeah.
What is that?
Yeah, it's another burn case. It's a
Yeah, maybe it
critical
can be added
resource
on later
group.
on. And Kevin, maybe that's something to schedule.
Sure.
Yeah,
I can. I'll reach out to Dr. Minigozo as far as scheduling.
Okay, and I'll wait for this. So if you can get me this within, so it's like evening there. So maybe in 24 hours or so, just put something together, Dr. Broecker, with the photos and your timeline, what happened, and her social situation, and and then I'll pass it along and see what the options are. Okay.
Yeah, I'll send a group email to the three of you after we finish up here. Yeah.
Good. Okay. Thank you so much.
Yeah, that would be great.
Thank
Thank you so much.
Mm-hmm. All right, I think that's pretty much it, right?
Okay. Yeah, that's what I was going to ask. Is there anything to finish up, Dr. Broecker, or besides the second case?
No. Yeah, I had
Okay.
a second case. I mean, I had some just discussion about, the fact that there's, burns are a huge issue in limited resource settings, and our options for management are very limited, and the mortality, again, there's limited evidence, but in general, the mortality and morbidity are greater. So yeah, I definitely am happy to discuss the critical care one later, because I think also discussing the critical care aspects of burns would be interesting in a low resource setting. We didn't get so much into that today.
Yeah, the other point, Kevin, is when will this? Can I get a link to the video of this conference? My colleague isn't here, but the surgeon that has an organization in South Sudan. Actually, it's near where I worked in Lachor, in the north of Uganda. It's probably a little farther from Bale, which is east of Lake Choga, I gather. But anyway, it's still within the region. And he might be able to provide services there. He's got a trauma hospital. It's not meant to treat acute burns, but he might be able to provide resources and assistance, and in fact might be able to help if the child is accepted in Boston. Might be able to help transfer the child from Uganda if she has no one that can go with her, that sort of a thing. But will there be a link to the video of this?
Yeah, what I normally do is I send the link to my colleague at the Pan American Trauma Society, and they put it on their YouTube channel. Yes. But in the meantime, I don't know how long that takes them to do it, but in the meantime, since this is kind of an urgent thing, I can just send you the link.
Yeah, if you can do that.
Directly to the meeting.
I have trouble finding the YouTube channel. These presentations are no longer on YouTube, or at least I'm not able to access the old ones, but they used to be. I did one presentation, used to be on YouTube, but no more. But anyway, if you send the link in the email, and then I'll pass it on to my colleague, and he's in Juba in South Sudan. So you know where that is, Dr. Broecker, just over the border from Uganda. And he attends these, and but he'll be able to watch it and see what he can do there, and whether there should be some transport arrangeable. And he often travels through Kampala anyway, so very good. So we'll see what we can follow up with this case. So very good case, worthwhile to have presented here, and that's the purpose, not only to learn but to help some of the people that you come in contact with in remote locations. Okay.
Great. I just sent the email to the three of you, so hopefully you should have it. And then Dr. Untracked, I'll get that video link ready and send that to you either later today or in the morning.
Okay, much appreciated, sir. Thank you.
Sure. Thank you for helping out with the meeting, Dr. Untracked. I appreciate that.
No, my pleasure. And glad to be back. I was missing this so much.
Yes, I know. I'm glad to have you back. Yes.
It's really, it's terrific. Okay.
Good.
Thanks.
Thank you, everyone. All right. Bye-bye.
Thank you so much. Bye.
Thank you.